Good morning, everybody. My name is Kevin Ha. I'm one of the fourth-year pathology residents here at the university, and welcome to my Grand Rounds presentation. I have no disclosures, so some of my objectives for today: educate on the historical origins of blood banking and transfusion medicine, discuss apheresis from a historical and technical perspective and on the different modalities, and from there further elaborate on therapeutic plasma exchange and its utility in the renal transplant setting. So my first exposure to essentially blood donations was in high school when, one of those blood donation trucks rode into the high school. They said, you get to miss an hour or half an hour of class, you probably get cookies at the end, and you can also save a life. All these things sounded really good to me, so I went to do it, and luckily didn't have any reactions, even though I probably didn't drink water beforehand and didn't eat any good snacks beforehand. But that is to say, this experience helps show how little knowledge I had of the complete process that is involved in blood donation. From this diagram that you can see on the slide here, there are multiple steps involved in the blood donation process and also for the apheresis process as well. Both blood donation and apheresis requires multiple steps involving the donor, the patient, manipulating the product, and looking at the outcome of the procedure. The difference is that with blood donation, you're merely collecting blood, whereas for apheresis, you might be collecting only a certain aspect, discarding a different aspect of it, or replacing a different aspect of it. But really, they kind of go hand in hand in the requirements to ensure safety both to the donor, to the recipient, and to ensure that you have an efficacious product. So that brings me to my first topic for today, blood and transfusion and its historical basis, because looking at it now, we see, as I mentioned earlier, in high school, blood donation just merely involves hopping in a cart that rolls into your school or workplace, getting something stuck in your arm, and getting cookies at the end. But really, as you'll see from this section, it took a lot to get to that point, and there's still ways to go and things to progress on that end as well. So all the way back in 1628, Dr. Harvey first published a book citing the circulation of blood within human beings. This established that there is potentially a closed circuit system involving some kind of fluid or blood that goes throughout your body and has some function in terms of potentially oxygenation or providing nutrients or getting rid of waste. In 1666, the first reported scientific transfusion was performed between two dogs. There isn't really much discussion of what the outcome of that case was, but it showed that it is theoretically possible to transfuse blood between two different animals of the same species and connect blood from an artery collection to the vein of another animal as well. There were earlier reports of supposedly, I'm not sure exactly what year, but one of the popes had transfusion, but apparently that blood was taken by the mouth as opposed to being infused into the vasculature, so that's not really a transfusion per se. A year later, the first reported transfusion involving human was performed in France. Jean-Baptiste Denis exchanged 9 ounces of blood from a lamb with 3 ounces of human blood into a 15-year-old boy. He was previously treated for symptoms of fever with bloodletting and was noted to be in low energy states and sullen. And after this transfusion was noted to be slightly more energetic and alive. So that showed that there was evidence that, hey, maybe this transfusion has some benefit. During this time, the idea was that that blood itself has certain properties, if you were to transfuse blood from a lion, you might get, more courage. If you have blood from a young dog into an old dog, they might become more energetic. So really, these early transfusions were very kind of like shot in the dark, postulating an effect without really understanding all the underlying mechanisms. He persisted in trying to attempt more transfusion after this first success with the 15-year-old boy. Although some had no fatal or adverse outcomes, others did. And specifically in December of 1667, about 6 months after his first transfusion attempt, he performed a transfusion of 5 to 6 ounces of blood from a calf into a gentleman named Anthony du Maurier to treat some behaviors that they termed as maniacal. And with the first transfusion, no change was noted, and they decided to repeat the procedure 2 days later. And subsequently, the patient developed tachycardia, perspiration, abdominal pain, and hemoglobinuria, what we would now classify as a transfusion reaction. He did survive that episode, and 2 months later, the wife came to the doctor asking to attempt another transfusion to treat the maniacal behavior. It's unclear whether an actual transfusion occurred or not. It seems more likely that a transfusion was not completed. However, the patient was noted to be deceased the next evening, supposedly without completion of the transfusion. This case went to court, and although the doctor was exonerated due to evidence of arsenic poisoning by the wife, there was a declaration by the court that there should be a ban on unsupervised transfusion, that transfusion should only occur under the supervision of the royal physicians of France. And from then on, transfusion research declined and essentially became outright prohibited both in England and in France. However, probably less than 2 centuries later, in 1818, Dr. Blundell witnessed some fatalities during delivery of babies and noted that these fatal uterine hemorrhages could have been treated with transfusion potentially. He was essentially the first person to conclude that transfusion should only occur between humans rather than goat or lamb to humans. And he subsequently performed 10 transfusions. 5 of them were noted to be successful, specifically for postpartum hemorrhage and post-surgical bleeding. The remaining unsuccessful ones the patients were noted to be more in sepsis or had some other malignancy diagnosis instead of just this bleeding. To help promote the transfusion, he also devised some instruments as well. As you can see from the picture, the idea is that the donor and patient have to be in the same room. You would essentially create a nick to try to get blood out of the donor into this cone-shaped device which collects the blood, and then with gravity's assistance, the blood would funnel into the patient and theoretically help the patient. As you may well think, this type of transfusion is not very effective. It is hard to gauge exactly how much blood is being exchanged, whether the blood is clotting before and transfusion is actually occurring, and whether the recipient is actually getting any benefit from this. So really, his 5 of 10 successful transfusions could simply just be, it just happened to be successful, or it could be that actually this method actually had function. In addition to the problems of actually doing the transfusion, there's also the other issues of patient risk, transfusion reactions, and things of that nature. So over the next few years, they attempted to improve on these methods. Instead of blood, in 1831, they attempted to use saline to treat a hypovolemic cholera patient with some noted success. Between 1854 and 73, they kind of used different things. They tried to inject IV cow milk. They tried to inject IV goat milk. The more interesting developments were antiseptics and sterilization. That was discovered by Dr. Lister in 1867, which helped make these transfusion procedures less risky, as there would be potentially a lower risk of infection. Additionally, in 1869, the idea of anticoagulation to prevent blood from clotting before it could be infused into the recipient was utilized by Dr. Braxton Hicks with sodium phosphate to help treat obstetric bleeding. Ultimately, in 1884, Bull published that IV injection of saline is the best substitute for blood, and subsequently it became the preferred method for essentially fluid resuscitation and kind of superseded blood as the idea of treatment. That brings us to 1901. Dr. Landsteiner in Austria published a landmark paper essentially describing the blood group. He initially described them as the ABC groups, which subsequently became ABO. He collected sera and red cells from 22 healthy people, including himself and his colleagues. So as a plug, if you have an experiment, maybe you should get your coworkers to help you. As you can see from this table, he noted that sera from the so-called Group A population reacted with Group B cells, but not with the Group A cells, and the same thing was noted with the Group B cells in reverse. And they also noted that Group C sera reacts with A and B cells. However, the Group C or Group O cells are unaffected by the Group A or B sera, which is a really important discovery in terms of blood banking and transfusion medicine. A year later, the blood type AB was discovered by Decastrello and Sterling. Although these blood group discoveries would certainly make transfusion much more safe, there are still additional issues that remain persistent, including, as I mentioned, how to actually perform this transfusion. In 1908, Dr. Carrel introduced end-to-end anastomosis of donor artery to recipient vein. Although this was not nearly as beneficial for transfusion itself, it led the way to organ transplant, which is in and of itself also an important discovery. Furthermore, in 1913 to 1914, there were independent discovery of citrate as an anticoagulant by 3 doctors in 3 different countries. And it was noted that this citrated blood could potentially improve the shelf life of collected blood, eliminating the need for the donor to actually physically be in the same room as the patient. Using this idea of citrated blood, the first attempt at transfusion of this blood was attempted into an anemic patient, and it was successful, showing the viability as an anticoagulant and storage preservative. And furthermore, around World War I, when more need of blood and blood storage, Dr. Roux used a sugar, dextrose, in addition to citrate to further improve the storage time of blood. So some additional discoveries in 1917, a physician in Germany highlighted the importance of pre-transfusion blood testing. If you're able to get the blood group of the patient beforehand, you can more narrowly navigate and direct treatment outcomes as well. And over the next few decades, additional blood groups were discovered. Importantly, in 1939, Dr. Landsteiner, who discovered the ABO blood system, also did work in discovering the RH system, which is named after the rhesus monkey that he collected blood and sera from. World War II further catalyzed the development of blood banking and transfusion medicine, as there would be a great need for collecting blood as well as getting the blood to where they would be needed on the front lines. A lot of countries needed to create an infrastructure to both store the blood and to transfer the blood. So this further catalyzed interest in improving the storage time of collected blood units as well as improving the collection methods. In 1940, Dr. Cohn developed a cold ethanol fractionation method, which was a discovery that allowed for component and derivative therapy. It allowed the separation of albumin from plasma, so that now albumin could be collected to be used for its oncotic properties. And in 1950, a major change was a change from reusable equipment, rubber tubing and glass bottles, to more disposable plastic blood collection, which further improved the safety as well as also potentially improving the storage time, as these are more closed units. However, with all these new discoveries improving both the efficacy and safety of transfusion, it also highlighted more issues that still needed to be worked out, including the high number of transfusion-related infections, transfusion reactions, and other potential issues. So in 1962, the first published case of transfusion-related hepatitis was reported. He noted 21.4% of around 11,627 patients who received transfusions developed a hepatitis. And from that, in the 1970s, the National Blood Property Policy was, rather than have paid blood donors, there should instead be a voluntary blood donation program, so as to avoid the incentives to donate blood if you are sick or carrying hepatitis or other infection. One of the really big epidemics, as I'm sure you're all aware, is the HIV/AIDS epidemic. First noted in 1980s with a case report by the CDC of an immunosuppressed patient. After this published report, multiple clinics reported cases with similar symptoms, and this soon became diagnosed as AIDS. And in 1985, the FDA licensed the first commercial test to detect HIV antibodies in the blood to prevent transmission of HIV. So, as this brief history tour shows, a lot has gone into ensuring that the blood collection is both effective and safe for both the donor and the patient, as well as to create a good product for usage. And similarly, as I will talk about in the next section, apheresis follows much of the same models. You still have a donor, a product, and a recipient, and there are multiple safety measures that one needs to take into account in order to, promote patient well-being. So going along with this history theme, let's go all the way back to Hippocrates. So he initially believed in 4 elements in the world, and within humans, these elements were instead the humors: blood, phlegm, black bile, and yellow bile. It's likely, back then they didn't have microscopes or ways to look at inside the body aside from bleeding or mucus from the nose or from regurgitation or things of that nature. So these 4 basic humors were the idea of that was what made up your body. And illnesses are due to an imbalance of these 4 humors. So treatment should consist of removing the excess offending agent through either bloodletting, purging, and so on and so forth. This idea of bloodletting was further supported by Galen by declaring blood as the most dominant humor. And famously, George Washington in 1799, who ultimately was diagnosed with epiglottitis and sepsis, was treated for his symptoms of fever and respiratory distress with bloodletting. So this was pretty controversial, as the idea was that the treatment ultimately contributed to his demise. So jointly with the idea that if a patient is deficient in an aspect, such as blood, and transfusion helps to replace that, there's also the idea that there's potentially some buildup of toxin or some other protein or molecule that has a negative effect on the body, that if you were to remove this from the patient, this could potentially be of some benefit. So apheresis derives from a Greek word that means to separate. It was first essentially coined in 1914 with the phrase plasmapheresis, and currently it is defined by the American Society for Apheresis, ASFA, as a procedure in which blood of the patient or donor is passed through a medical device which separates one or more components of blood and returns the remainder with or without extracorporeal treatment or replacement of the separated component. So as I mentioned, in 1914, a paper was published highlighting the term plasmapheresis. In this paper, he collected blood from dogs who had undergone bilateral nephrectomies, and he separated this collected blood into cells and plasma, discarded the plasma, and reinfused the cells in a suspension of saline. He noted that compared to the control dogs, it appeared that the dogs who had received this reinfusion of cells had a longer survival, and termed this procedure plasmapheresis. When I read about this seemed more in line with the idea of dialysis, as these dogs had undergone bilateral nephrectomies, but there potentially is some value in this plasmapheresis in promoting the survival of these dogs. However, even after the publication of this paper, there was not really any widespread adoption of plasmapheresis as a viable treatment modality, both based on based on a lot of issues, including the duration of the treatment, requiring the necessary equipment and infrastructure to actually perform this procedure as well. However, in 1960, first paper was published stating a specific clinical use for plasmapheresis in Waldenstrom's macroglobulinemia. So in practice, apheresis can be supervised by both pathologists, hematologists, and nephrologists. And in terms of the pathology residents themselves, they may have varying exposures to apheresis as a practice, depending on whether their institution has the pathology department oversee apheresis or not. There was one paper I looked at that noted that the residencies that did not have a pathology-run apheresis department generally had a lower level of knowledge of apheresis, which seems to make sense, as you would specifically have to do a rotation with nephrology or hematology in order to get this exposure to apheresis if you're at one of those other programs. And of note, all AP and CP only pathology residents should have some knowledge of apheresis, since it is tested on the clinical pathology boards. In terms of the ACGME milestones, there really is only a brief blurb about apheresis. It's kind of lumped in the procedure section with bone marrow biopsy and really isn't very elaborated on. So in 2012, ASFA created a companion milestone specifically for apheresis, getting at the clinical skills and reasoning, patient management, and clinical care management of the donor, and core knowledge of apheresis itself. So some of the basic aspects or basic concepts that are present in pretty much all the different apheresis procedures is the idea of collecting the blood and separating it into its different components, replacing the fluid back into the patient and calculating the appropriate volumes necessary, as well as having a vascular access to actually get at this blood. And this is one of the apheresis machines, Spectra Optia. As you can see, the patient would be in a bed with the machine bedside. They would have some kind of vascular access. It would be processed through these disposable plastic instruments and separated with either centrifugation or filtration into the different components, plasma, white cells, and red cells. So, as I mentioned, centrifugation or filtration can be the method to achieve this separation. The earliest apheresis equipment involves centrifugation, and the idea is that with a spinning force, the most dense components, in this case the cellular components, are typically furthest away from the axis of rotation, whereas the less dense components are closer to the axis of rotation. This method is not entirely perfect, as in the interfaces between the areas of separation there are some levels of mixing. So if one were to draw, let's say, red cells close to a transition point, you might also get some granulocytes, which could potentially cause some issues when it's being transfused into a patient. This centrifugation can be intermittent flow or continuous flow, depending on your desired method of collection. If you want to, essentially have a constant amount of blood outside the body and flowing continuously, or have limit the amount of blood outside the body at a time. The idea of filtration is separation based on sizes instead of density. Using membranes with different pore sizes, they're able to separate blood into its different components. One can also combine these two methods to attempt to attain the positive aspects of both methods, so as to lower the amount of G-forces or the forces needed to separate and spin the blood, and to actually further get rid of the issues with these transition areas as well. As I mentioned earlier with the transfusion, anticoagulation is important, as anytime blood is outside the body, it would like to clot and coagulate. So to prevent blood from clotting when it's within the equipment, prevent the complement from activating by reacting with the plastic tubing, citrate is commonly used, and it functions by essentially scavenging up the calcium to help prevent complement activation. This is generally well tolerated, as even when what is returned back into the patient, it may contain some citrate. The body has some compensatory responses in order to increase the amount of calcium by releasing it from bone or albumin, or by increasing the resorption from the kidney. Some patients may experience some symptoms of hypocalcemia, generally not very severe. They may feel some tingling in their mouth or in their fingers as well. And additionally, citrate is typically rapidly metabolized by the body, but it is important in terms of the procedure itself to set a adequate flow rate for citrate, so as not to infuse too much citrate into the body. The potential other anticoagulant is heparin, and that depends on both based on the anticoagulant requirements, and specifically within children, since they have a relatively lower body size, lower blood volume, the amount of citrate would potentially be higher than relative to the blood volume compared to an adult. So a combination of heparin and citrate might be necessary. So in terms of replacement fluid, as I mentioned, saline is the fluid of choice for fluid resuscitation. However, in apheresis, typically what is used are colloids such as 5% albumin or plasma. The main purpose of these fluids is to maintain intravascular volume with additional secondary purposes to simulate the function of blood, including the plasma proteins, the osmotic pressure, and the electrolytes. There are pros and cons to each of these different fluids, both based on the price, based on whether there's any risk of transmission of any potential pathogens or infections, such as with plasma, or whether it repletes the oncotic osmotic pressure, such as albumin. And specifically with the procedure, although I mentioned that the purpose is to maintain intravascular volume, you can also secondarily do other functions such as repleting the patient to maintain their fluid balance, or to decrease their fluid balance or increase their fluid balance, depending on whether they start out as hypo or hypervolemic. So in terms of determining the appropriate volumes, a lot of the modern apheresis equipments can do the calculations themselves. Typically, the parameters that are needed are the gender, the height, the weight, and the hematocrit, as this gets at the estimated blood volume and therefore the plasma volume that the patient potentially needs to be processed. And these can be done by either nomograms, using rules of thumb, such as saying most adults have an estimated blood volume of 70 milliliters per kilogram, or doing the actual calculations themselves. And some of the other considerations is that by rule, less than 15% of blood should be outside the body at any time, because if there's more blood outside the body, that has a higher risk of more severe adverse reaction on the part of the patient. And additionally, blood volume also varies depending on body habitus. Water typically has less blood per kilogram, while muscle has increased. So some additional manipulation needs to be done in order to appropriately calculate the volume. In terms of the plasma volume exchange during apheresis, even though you process 1 or 1.5 full amounts of plasma volume, meaning that essentially you're treating all the plasma that's within the human body at a time, you can't really remove or get at 100% of what is in the plasma. Using this equation of y equals y0 with exponential x, with y being the final concentration and y0 being the initial concentration. As you can see, even after 1 to 1.5, you really only remove 60% of your targeted molecule or component, and really, even if you do much more than that, you really never get at 100% removal. And this model is also assuming that the intravascular space is closed so that there's not a redistribution from the extravascular compartments. Specifically, there have been differences noted with different molecules, such as the difference between IgM and IgA. Since IgM is predominantly intravascular, it stands to reason that how much you expect to be removed is what is removed, whereas IgA has both the intra and extravascular compartment. So even if one were to remove even 90% of what's from the intravascular compartment, there's still some more redistribution from the extravascular compartment to make it look like you have removed less than you did. The next component of apheresis is having a vascular access. As the procedure requires high flow rates, These typically require a larger catheter that can tolerate higher flow rates. These can be either peripheral or central. For central lines, the catheter must be relatively short with a wide diameter so as to minimize resistance. I don't remember the exact formula, but resistance is like 8 pi or something, and length. So really, the length and radius really affect the resistance to blood flow as well. And double lumen dialysis catheters can also be used for the procedure. So as I mentioned, for the central and peripheral, typically peripheral is recommended, as placing a central line is not without its own complications. However, if the donor is expected to be undergoing multiple treatments, then potentially a central line could be recommended as well. So as I mentioned, apheresis is typically well tolerated. The most common side effects may be associated with that citrate infusion of the hypocalcemia. However, the patient may also have some symptoms of hypotension, vasovagal syncope, some allergic reaction as the blood flows through the plastic tubing and plastic instruments, but typically generally very mild and well tolerated. Some of the more severe complications include issues with the access site itself, potentially an air embolism and loss of blood components. There is some risk of bleeding and thrombosis with centrifugation and running the blood through the machine. There is that potential that platelets could be activated and result in a drop of platelets. Additionally, with plasma apheresis or plasma exchange, you're drawing off the plasma and getting rid of some of those components of the complement and coagulation system, which could lead to risk of bleeding. Typically, these levels recover within a few days of procedure. Of note, fibrinogen typically has a slower rate of repletion. So if the patient starts off low with fibrinogen or has had a recent procedure, then your choice of replacement fluid may be guided by that as well. So there are many different types of apheresis procedures, both for donor and therapeutic purposes. In terms of donor apheresis, collecting platelets with apheresis compared to collecting whole blood and separating it after that, the benefit is that these platelets collected by apheresis are typically within a closed system, so they have a longer shelf life compared to that collected from derived from whole blood as well. And additionally, the other benefit is that you can further tailor what you're collecting. As for donors who have a blood type of AB, obviously the plasma is more desired, as they tend to not carry the antibodies to the other blood groups, whereas the AB cells are not desired, as really there's only a small, relatively small number of AB type patients. Additionally, you can collect specifically white cells, you can collect red cells. Of note, for stem cell transplantation, typically apheresis is used instead of an actual bone marrow biopsy or bone marrow collection, as I mentioned, these apheresis procedures are tolerated much better than having a surgical procedure or a bone marrow direct harvest procedure. Additionally, when the blood is outside the body and being separated by the machine, another different modality that could be used is extracorporeal photopheresis, where sorolin is infused into the product and treated with UV light to serve in some immunomodulatory function as well. So a lot of people seem to think dialysis and apheresis are pretty similar, and especially since some medical centers have nephrologists managing apheresis, there are some similarities, but there are some differences as well. Dialysis uses filtration with a permeable membrane to specifically get at smaller waste molecules and toxins. It does not get at the proteins in the plasma, such as immunoglobulins or clotting factors. And since everything that's being processed by the machine is being replaced or being reinfused into the patient, it does not require volume replacement. Alternatively, apheresis removes components from the plasma and requires replenishment with replacement fluid. I didn't know how to do the slash sign through the equals, so I used computer programming exclamation mark equals, which means not equal, plasma exchange. So both these terms are used interchangeably in the common vernacular. However, they really get at different things. Plasmapheresis really only processes less than 15% of the total plasma volume, and typically does not involve replacement by a replacement fluid. And its most common usage are for donor plasma collection rather than for therapeutic reasons, such as collecting plasma for manufacturing into albumin, IVIG, other concentrates, and reagents. Therapeutic plasma exchange, or TPE, involves removing the plasma and replacing it with a replacement fluid. So some of the indications for TPE, there have been many reported different disease states and different indications for performing TPE. And like with everything in medicine, procedures should only be performed if there's efficacy and indication, some effective treatment regimen, and trying to minimize any of the adverse side effects. So specifically with therapeutic plasma exchange, ASFA has published guidelines breaking it down into both category and grade, and reviewing all the published literature to help get at, is TPE indicated or not. So in terms of the category, it goes from 1 to 4, whether it is a first-line therapy, whether it should be second-line, whether the role has not been established, or whether it is actively contraindicated or harmful. And in addition to category, there's also grading, whether there is a strong recommendation with high, moderate, or low quality evidence, or if there's a weak recommendation with also high, moderate, and low evidence as well. So the idea behind therapeutic plasma exchange is that it can get at different mechanisms, such as removing these pathologic antibodies, such as in potentially multiple myeloma, Goodpasture syndrome, getting rid of donor-specific antibodies within a pre-transplant patient, replacing deficient plasma components, removing other inflammatory or immune complexes, or trying, really all these mechanisms try to get at some kind of immunologic function, and ideas that therapeutic plasma exchange has some benefit in that. So the table of the different diseases and indications is much too big to include on one slide, so I just took some choice examples. So as you can see, for familial hypercholesterolemia, they looked at the different modalities, whether they removed the lipid apheresis only, or whether a full therapeutic plasma exchange was performed, and whether the patient population were homozygotes, heterozygotes, or otherwise were homozygotes with a small blood volume. Really, only the homozygotes are a category 1 first-line therapy. The other two are considered second-line therapies with strong recommendation with high-quality evidence, or strong recommendations with lower quality evidence. As you can see, they really go through all these different disease states and indications and the different modalities and give a category and a grade. I realize there's a lot of words on this slide, but just disregard this side. But in terms of all the indications and diseases that they looked at a total of 87 diseases and categorized them into 179 indications. The largest category was Category 3, 70, there were 96 of them. This category is the basket where it is really unknown whether TPE has benefit or not. There isn't really good evidence one way or the other to show whether it is indicated or not. For the Category 1s where it is indicated as first-line therapy, the majority of them have a strong recommendation with a ranging from high to low evidence. And specifically within this Category 1B, which is a strong recommendation with moderate evidence, is the renal allografts, both ABO compatible and ABO incompatible, and whether it is for desensitization or for antibody-mediated rejection. So that is a relatively smooth transition into my next topic, kidney transplantation and apheresis. So I don't purport to be any kind of expert in renal transplantation, but as a baseline, a myriad of conditions can result in the so-called end-stage renal disease, and this end-stage renal disease can be managed merely by symptomatic palliative treatment, by dialysis, or for kidney transplantation. Transplants can be from living or deceased donors, and in order to prevent some rejection, major antigen systems that are matched include the ABO blood group and the HLA, or human leukocyte antigen group, as well. A perfect match is plus 6 out of 6 for HLA. However, due to the relative shortage compared to donor to necessary recipient, many incompatible transplants are performed. These imperfectly matched allografts have a higher risk of rejection and graft failure, and a higher risk of donor-specific antibodies. So rejection can occur following transplantation by a number of different etiologies. It can include inadequate immunosuppression, noncompliance with the medication, infection, some surgical complications, or some other etiology such as recurrence of the patient's primary kidney disease. Clinically, the patient may present with decreasing urine output, hypertension, increasing creatinine compared to baseline, fever or pain. One of the important clinical signs for acute rejection is a 25% increase over baseline in the serum creatinine. From the pathology standpoint, the Banff working classification of renal allograft pathology, first published in '93 and latest in 2013, tries to create a consensus infrastructure or scaffold in order to consistently diagnose whether a renal biopsy has some signs of rejection or not, and further classifying it as acute or chronic. Of note, antibody-mediated rejection has been reported from 1 to 10% of transplants, and they are thought to be due to antibodies against the donor HLAs, to the ABO blood groups, or other antigens. So antibody-mediated rejection is thought to result in activation of the classical complement system, specifically where these donor-specific antibodies bind to the HLA antigen and activate the C1 complex. And one of the byproducts of this activation process is C4D, which is a degradation product. And of use in pathology is that this C4D product remains covalently bound at the site of action for up to several weeks, so it can be of use in terms of immunohistochemistry and diagnosing by pathology. So these donor-specific antibodies can arise de novo or from pre-sensitized patients, and the highest risk of antibody-mediated rejection is those in patients who have received a previous transplant or have a high pre-transplant panoreactive antibody. So this is just a table showing you, what the classification in the BANF system looks like, whether it's acute or active, chronic active, or if there's merely C4D staining without any evidence of rejection. And within the fields, it looks at if there's histologic evidence, if there's antibody interaction, typically shown by the C4D staining, and if there's serologic evidence of there being DSAs present. In terms of managing these episodes of rejection, the Kidney Disease Improving Global Outcomes have published some guidelines in 2009. They typically recommend a biopsy prior to treating the rejection. They recommend a immunosuppressive regimen, and additionally, for antibody-mediated rejection, they recommend plasma exchange, potentially IVIG, anti-CD20 antibody, or lymphocyte-depleting antibody. Of note, the rituximab, which is an anti-CD20 antibody, seems like it wouldn't work because the idea is that these donor-specific antibodies are produced by some long-living plasma cells, and these cells are not CD20 positive, so it doesn't really make sense how this rituximab works in treating this antibody production, as it doesn't eliminate the plasma cells at all. But studies seem to show that it does seem to be of some benefit, so it is still a recommendation. And with all the new drugs involved in complement, such as eculizumab, the idea is that potentially it could be used to prevent damage to the kidney by preventing activation of the complement pathway. So in terms of TPE specifically, the idea is that removal of these donor-specific antibodies via TPE or immunoabsorption may be beneficial in conjunction with the immunosuppression. However, it is hard to get at whether all these more recent reports of the efficacy of TPE is due to the improved detection of DSA, improved anti-rejection medications, or if there's better classification with the BANF criteria itself that is helping to promote this so-called efficacy that you see. So some of the more technical aspects of TPE is that 1 to 1.5 total plasma volume exchange is recommended daily or every other day. Whether the patient is receiving the procedure for TPE or for desensitization further determines how many procedures you do. On average, for antibody-mediated rejection, 5 to 6 is performed. For desensitization, other additional modalities such as IVIG and rituximab may be used. There's still some controversy whether IVIG should be used after every procedure or at the end of the 5 to 6 procedures. So it is still an area that needs to be more clearly defined. So specifically the ASFA guidelines for the renal transplantation, as you can see, it breaks it down into the different procedures, and really for all the different indications, they're really grade 1B. They have a strong recommendation with moderate evidence, and really the only one that has a second line recommendation is for desensitization for a diseased donor transplant. So some of the ongoing issues with getting at if TPE is effective is determining the optimal replacement fluid. Should we use albumin? Should we use plasma? Whether TPE is actually having an effect in the treatment, or whether it is in combination or simply because of the other modalities such as the new immunosuppression medication. The number of procedures necessary to treat an episode of rejection. And of note, I included this picture from the previous slide. They really had no good randomized controlled trial for patients with receiving TPEs for desensitization or a high panel reactive antibody. And that gets at the issue of, can we get patients and have a control group where we perform sham plasma exchange? It seems like a really big hurdle to overcome in terms of creating that study as well. Since I'm running slow on time, I'll have a brief aside on a research project that I'm currently working on. So we looked at between January of 2005 to May of this year, we looked at all the patients who underwent apheresis for renal transplant rejection. We looked at their medical records, including the demographic data, some of the laboratory and pathologic data as well. And really, it's a very preliminary project, so we haven't had clearly defined endpoints as well. Some of the initial ones that we were looking at was whether there's allograft survival at 1 year or 3 years, whether the patient actually survives post-transplant and apheresis, and whether the patient needs a return to dialysis or complete transplant. Really, this project is trying to get at, is TPE effective in treating transplant rejection, and what are the different variables that are required to look at this. So in that time period, there's a total of over 2,000 procedures. That comes out to 280 patients. On average, each patient received 5 total apheresis procedures, or 1 series, with some patients receiving several series of apheresis, greater than 4. Data collection involved looking through EPIC, COPATH, and also looking at the histotrack or HLA data as well. So in terms of the preliminary collected study population, of the 280 patients, there's a little less than 50-50 split between genders. The mean age is around 43 years with a range of 2 years old to 85. There is more of an adult population compared to pediatric. There's a relatively even split between living and deceased, and the majority of patients received only 1 transplant. However, some received greater than 3 transplants, and a number of patients had a concurrent or simultaneous pancreas transplant, and there were some other organ transplants as well. So this is a work in progress. There is a lot to be completed. More numbers need to be crunched, and more set inclusion and exclusion criteria need to be performed. And we also need to correct for patients with multiple renal allografts or multiple series of apheresis to make sure that doesn't confound any of the data. So in conclusion, I went over some of the history and background basis of blood bank and what's involved in the testing. I went through, the apheresis, the procedures, and some of the various functions, and specifically therapeutic plasma exchange with regard to renal allografts. So these are my objectives again, references. So this was taken last week. It was my first time walking on a frozen lake, so it was kind of scary. So like last week, hopefully this presentation doesn't leave me on thin ice. Thank you for your time, and I'll take any.
In your study, do you plan to review the slides? What one of your lines talked about?
Yeah, I collected all the accession numbers, and I'll probably pull the slides and work with Dr. Boo and working with Dr. Andy Johnson, Dr. Tumer, and HLA as well. So, yeah.
There's a very interesting history of
Oh, yeah.
transfusion. It was pretty interesting. Just an anecdote. Peyton Rouse, who you referred to, I was surprised he was in this because he really he discovered the first tumor virus. He called it a filterable agent in fowl chicken. It was a Journal of Experimental Medicine article in 1906. And he, like many fields, no one believed it. And he worked in kind of anonymity, but actually some viruses were discovered here too. The Bittner virus and it's a dispute of the show papillomavirus in rabbits, the rabbit they
Oh,
use
sure.
and stuff. So, but he ultimately got a Nobel Prize like 40 years later. Good work.
Interesting.
Press on, everybody.
Kevin, as a follow-up to the history, I was impressed sometimes that changes take time. And
Yeah.
I'm referring back to your one slide where you showed that the transition from using rubber tubing and glass slides to
Plastic.
plastic disposable
Mm-hmm.
containers
Yeah.
occurred in 1950. Turns out I was in medical school in the very late 50s, and we were still using
Oh, really?
reusable rubber tubing,
Uh-huh.
glass bottles, and reusable needles.
Wow.
This was in the late 50s. So it took a little time for that to happen. Of course, I was in an underdeveloped area of the country.
There was no electricity either.
That's interesting. All right. Thank you, everybody.